Listo.
Hello
Eso.
to everyone, and greetings from Italy. Thank you, Professor Shahab, for this kind invitation. It's an honor to me to be here with all of you today. Endoscopic Submucosal Dissection is the topic of this section, and technical innovation and new application is the topic of this presentation. Here, my disclosure, and let me start from the increasing interest then on endoscopic submucosal dissection that is highlighted from by the boost of the literature on the last year on this topic. But boost means also diffusion of the procedure. So we applying this procedure so much than before, and this can be sometimes means also emerging technical issues, and we need to overcome this type of difficulties. Guideline-based innovation talk clearly about what mean doing a procedure with a high complexity and like ESD. So we need specialists dedicated tools for be a good center performing a referral center performing the section. But ESD didn't start with all these tools, so we didn't start with this device. In the first case, the reported was probably performed with a tip of a snare, and then by um, um, devices that was projected by Professor Yamamoto and the support of industry specifically for this procedure. From the first time today, a lot of things changed and are changing. We are now have innovation in terms of devices, in terms of traction systems, in terms of endoscope with more flexibility than before to allow best and ESD and also a better way to perform this difficult procedure. But also skills in terms of strategy. We started with conventional, but we passed through a different type of procedure, and we need to know and apply sometimes all of them for different regions. Myself started with to observe a lot of procedure performed just with a single device, with a single type of cap. But during the time, new devices arrived, like with insulated tip, tie allowing us to inject through the knives without using a needle, and then system electrosurgical unit dedicated for DSD with also injection pump dedicated for this type of procedure, and different type of cap, and also high performance endoscope for this with also channels in different positions for make ESD easier. And so conventional dissection, these are three cartoons on pocket creation method and tunnel ESD. That's like I told before, we need to perform all of this procedure during in our experience. This depends from the mission. Also underwater, I consider underwater ESD also an innovation. Sometimes some experts are using it as other one now, but what we need to know is that what could be we can reach, what we can add to our experience with this new innovation, with the change of paradigm. Probably with pocket with underwater ESD, we managed to have a less adverse event, like post-coagulation syndrome, probably due to reduction of current transmission during the procedure to the wall of the and to the body. And so we are using in underwater ESD for obtaining a better coagulation vessel, avoiding device changing during the ESD. And I can are showing you here a video to you about the use in a different way the current this type of force. In this case is a forced current in wire 3 bio here be used with 0.3 setting. In this case, we managed to obtain a pre-sealing effect on vessel, avoiding to switch to a forced for coagulation, so coagulation forced. But what we easily do in this case, we do perform dissection, for example, for instance, with the swift coagulation, then we switch to 0.3 forced coagulation, obtaining when the vessels become completely whitish, we will switch again to dissection current and start. Here another case, again 0.3 forced coagulation, pre-coagulation to the left side or right side of the vessels, and then when the whitish effect is completed, we switch again to dissection current and continue our procedure, like you can see here. This just to say that we are more a lot of current available, and we should be ready and should be trained to use them in the best way for our clinical practice. Another current is a precise sect introduced by ERB. This is a current that should allow us to do dissection and coagulation, avoiding change of current, avoiding change of setting, because the electrosurgical units have like a lecture of the type of resistance, of the type that we are treating, so allowing us and supporting us in the different moment of the dissection. Like you can see here, a big vessel was treated with always the same setting of precise, just a little bit of bleeding started, but was easily controlled, avoiding change again to a coagulation forceps. So triangulation, we are talking a lot of triangulation. There are lots of publication, case series, and proposed from different groups, from Japanese too, and about how to obtain triangulation, to obtain something similar to surgery, to do dissection with in a better way and also easier way. This is the group is a pilot study from Humanitas group about this platform. This is like an overture proposed by Boston RI system to give to our endoscope some adding channels for traction and injection dissection. And these are a lot like we are seeing during this time a lot of publication, video, and presentation from French group, Pioche, Jeremy Jacques and colleagues about rubber band technique for traction, multi-traction. This is a series with a good speed of dissection, with a good maintaining good level of quality of dissection. So again, this is a platform we can see introduced from recently introduced by Fujifilm. This is the track motion. This is a platform that we need to install on a double channel endoscope. It's easy to set, and like you can see, it gives us the possibility to have adding heads to grasp, rotate, and track the lesion during this section. Like you can see now a model of the procedure. We apply this procedure. We have the possibility to apply it here in our unit, and this is probably could be a good support for in the future. What we need to absolutely is a good training, and because this type of platform, this type of innovation also changes our way of working and our way to perform this section. So without training, some also impacting innovation could be lost in the time. So I think that the training is the basis of for specifically for this difficult and complex procedure, and sometimes also system. Like you can see here, this is a different way to move your hand. This is a different way also to stay outside of the lesion, differently than pocket or also tunneling. So we need to work and train about this. And having new technologies, having new strategy means also to face with more and more difficult cases. Here you see two cases I selected to show you some highlights. On the left side, there is a lesion in the transverse colon that you can see there is a tattoo under the lesion. So we applied traction with the rubber banded clip to obtaining a good exposure of the layer in the submucosal space. Here also a bleeding due to the difficulties to understand where the vessel were. And then we are also fibrosis. So we need to also cut with endocut, avoiding coagulation currents. In the right side, and the implicit is the application of the tunnel technique for a really long lesion that's involving the dentate line, starting from the dentate line to the retrosigmoidal junction. Like you can see, I think this a lesion like this is possible to be done just only applying the right strategy, applying the tunneling, because differently it's impossible to dissect a lesion and block a lesion like this. And having new technologies, having new strategy means also to face with more and more difficult cases. Here you see two cases I selected to show you some highlights. On the left side, there is a lesion in the transverse colon that you can see there is a tattoo. And then the per-anal endoscopic myectomy. This is the PIME. This is a new a new procedure that we are doing, and something that we are doing the last years to resect complex lesion in the lower rectum and also in the distal stomach, sometimes also in the esophagus for selected cases. But this innovation, this new background, and these new knowledges are pushing us to do really difficult, as always, more difficult things. Pushing us to do really difficult, as always, more difficult things. Pushing us to do really difficult, as always, more difficult things. Like this is a case where we used ESD for, but it was not an endoscopic submucosal dissection. In this case, you will see an endoscopic transrectal dissection, probably because we had to you apply dissection to solve recurrence after transanal microsurgery, and sometimes we had to expose the mesorectal fat to obtain an en bloc resection. But also this case, we applied tunnel, we applied traction, and we applied all knowledges and background for the management of these difficult cases and this difficult lesion. But fortunately, we managed to obtain an R0 resection, avoid a really complex surgery for this patient too. So, new innovation, more difficult cases, and some things same happen like in for the further perspectives. I think, strongly think that we will always apply, especially in the rectum, but probably not only in the rectum, dissection also after chemo radiation. First, there are some publications in this sense that are proposing this type of experience to avoid really surgery that sometimes can really affect the quality of life of our patients. So this is like, for example, a potential algorithm to do it for local advanced rectal cancer, neoadjuvant chemo radiation, then restaging, and if there is a clinical response, doing ESD. But this case means doing ESD after chemo radiation. So we had to afford fibrosis, probably severe fibrosis, applying new strategy, new technologies, because without them, what I think would be impossible to obtain a R0 and a good result for this type of patient and lesion. So we need to share knowledge, skills, and experience. Let me show my last experience in Cairo, in Alexandria, with Ahmad Medkur, and a lot of really interested and passionate colleagues. I was really happy to be with them recently in Cairo, in Egypt. Thank you for your attention and again for the kind invitation. Let me remind you Endomed 2025 that will be held in March, directed by my chief, Roberto Dimitri, that is there with you. A greeting again from Sicily and thank you. Bye.